Good morning, everyone. Thank you, Anne-Marie. Very happy to be here today and also wanted to say thank you to all the patients and caregivers and friends. You're the reason why we do what we do. It was great to learn alongside of you yesterday, learning about immunohistochemistry, different aspects of imaging, and as Anne-Marie said, today we're shifting gears a little bit. So today we're going to be talking, or I'm going to be talking a little bit more about holistic care in HATTR, and I'm going to talk a little bit about what that is and a recent survey that went out in Delphi panel to come up with consensus recommendations of what holistic care in HATTR really should encapsulate. So we'll learn a little bit about what those recommendations were, how they can be implemented in this in patients in Canada. And what I hope to do is, towards the end, because we probably won't need all the time, is get feedback from you, not just me speaking to you about what's missing, what's working well, what's not working well, and how, as an industry and industry partners, we might be able to support you and to support TAC to support you. I'm just going to move that up. Okay, so a little brief introduction. So we heard a lot yesterday from all of our great passionate physicians and healthcare professionals all about all these different advances in HATTR management. Despite this, and just from speaking to many of you over the last few years, there's still a lot that's missing. Major unmet needs in patient and symptom management. And part of this is because we know that it affects your entire life. It's not just your nerves, or it's not just your heart, it's the whole body. And not just your body, but your social, your physical well-being. So in order to help reduce the burden of disease, there's been a call through patient advocacy groups really all over the world, and that's what led to this survey and recommendations, that there needs to be more expansion of services, a holistic footprint in the management of this disease. And that's what I'm about to present to you now, is sort of the outcomes of this Delphi panel, which I'll walk you through what that means right now. And part of it sort of at its core, and we'll define holistic care in HATTR in just a moment, but it is the physical, social, and mental health as really the patient at the center, and addressing all of those needs. Okay. So what did we do? So this was an Alnylam-supported Delphi survey, which was ultimately published. And over the last few years, we've been engaging with organizations such as TAC, such as with Anne-Marie and Keith. And this has been going on all over the world. And basically, the idea was, can we come up with a consensus on how to better manage patients? So to do this, we put together what's called a Delphi primary panel. And this was made up of 14 patient advocates and specialist physicians that come together to discuss a broad range of issues to address patient needs and what recommendations we can do to put forward to better patient care in HATTR. So you can see some of the countries there. We've got expert physicians from Europe, as well as allied health, and patient organizations also primarily based in Europe, but what I will say is Canada also had a voice in this. This was just the primary panel, and the steps are primary panel sort of comes up with themes or ideas to focus on, and then it gets broadened out through the rest of the world to vote and obtain consensus on them. So when this primary panel was first convened, they said, okay, what are the different challenges or opportunities that we can focus on when it comes to holistic care in HATTR? So you may not be able to see everything here, but it basically addresses, okay, how about early identification of the disease? Did the light just go out there? Genetic counseling, is this a gap? Is this being done? Does it need to be done in all patients? Multidisciplinary teams. Emotional quality of life, spiritual needs and support. So there's a whole host of things. So can we refine this a little bit and come up with certain aspects of holistic care that should be included, that all patient advocacy groups and all expert physicians in allied health can agree upon, that should be focused on? And if it's not being focused on in a particular country, how can we address that? Okay, so the Delphi process, I'm not going to go through line by line everything, but essentially you get a group together of patient advocacy groups and amyloidosis expert physicians and allied health partners. You do a literature review. You send out a survey to all of them to come up with various themes to focus on. Once you do that, this primary panel will then sort of go bit by bit through this and vote and come up with recommendations of what are some, what are sort of a finite number of items to focus on, and come up with recommendations that we can all agree on. And it goes through a cycle of voting so that you get as much consensus as you're able to get. Okay, so we started this a few years ago, and once we came up, or the primary panel came up with recommendations for holistic care in HATTR, we had over 120 physicians and patient advocates in 27 countries vote on these different recommendations. And what we found is that the majority of them endorsed what the primary panel said. So we had consistency across many countries throughout the world on what are the gaps in care of the patient, not just treatment, but the holistic whole patient view. Once we did this, this was published, and it was one of the first consensus recommendations in this patient group ever that incorporates patients and caregivers. In the pie graph to the left, there's a breakdown of the different people that voted. So we've got neurologists, cardiologists, patient advocacy groups, allied health physicians, internists. So there's a nice cross-section of expertise and knowledge in amyloidosis and different viewpoints from both the patient and the physician view. And this was published in the BMJ in the last year. Okay, so what did they talk about? So I explained what the process of how to talk about what they wanted to talk about, but what did they actually discuss? So what came to light, so when I showed you that big sort of pie chart of there's all these opportunities and challenges, they really were able to distill it down to 7 key themes. And I'll go through them now briefly, but the first was on early diagnosis and access to treatment, disease monitoring and organization of care, maintenance of physical, mental well-being and quality of life, family-centered care and caregiver support was obviously very important, patient-physician dialogue and shared decision-making. Remember that because that was actually brought up to be quite important. Access to community social support, and finally, spiritual support and social networking. So we have these core themes. And within these themes, what are different things that we can focus on and obtain consensus on that we need to focus on in this patient population? Okay, so here are the key survey findings. In the publication, it gets into much more depth. I'm not going to do that here today, but just really focus on some of the key items. So some of the key survey findings from the Delphi survey. There were several issues. I'm going to focus on 3. So the first was on this bucket of early diagnosis and treatment initiation and a coordinated multidisciplinary care team. So these percentages are just looking at the different, these over 120 PAGs and physicians that voted, and most of them agreed on these recommendations, which said, they agreed, 91% agreed that genetic testing should be mandatory to confirm a diagnosis with initiation of treatment immediately in all eligible patients. Another important thing that they agreed upon is that patients should be managed at centers qualified to provide multidisciplinary care. There should be, especially when patients are being followed up, sometimes you don't have an appointment for 6 months, 12 months, 18 months. There should be an interim either through telehealth or telemedicine, sort of a checkpoint with those patients, especially if there appears to be some progression or worsening of symptoms. And then lastly, a timely and regularly multidisciplinary monitoring of asymptomatic gene carriers. So we know that HATTR is, by definition, a hereditary disease. So when family members are often found to harbor this mutation, they need to be, according to the consensus panel, should be monitored right away and either treated or managed at first onset of symptoms or first sign of disease. So that's the first bucket. The second key survey finding was on maintenance and independence and quality of life with a tailored family-centered care plans, including supportive care. So there's a lot there. So what this means is, or what the survey came out and from physicians and patient groups, was that there needs to be access to pain management programs. Sexual health services are lacking, psychological services are often lacking. So we need to do a better job of providing this in the local countries or towns, provinces in Canada. And this should be part of this total package of holistic care. Next, there should be early assessment or much earlier assessment of patients that have rehabilitation needs, so providing mobility services, physiotherapy, mobility aids, just to maintain or help maintain autonomy in patients with HATTR. And you could argue this would go across not just HATTR, but across the amyloid community. Psychological support was identified as being very important, especially in moments of crisis where patients are feeling unsure, there's a new symptom or there's something new that's happening. You need to be able to provide that. There should be mechanisms in place to provide psychological support, and where to go. So it's one thing to say, yes, we should do all these things, but where do you go when you need help? So if you're in Toronto, you might have or if you're in Calgary and you can walk to Dr. Fine's office in 10 minutes, you might have better access versus if you live 3 or 4 hours away, it's different. And then lastly, most of the respondents agreed that, and this came out, is that should have access to an expert nutritionist because there's often unexpected weight loss in patients and how to manage that. So that's sort of the second bucket of maintaining quality of life, autonomy, that the Delphi panel agreed that we need to do a better job of. Lastly, that I'll cover was focusing on this key bucket or item is an open dialogue to support shared decision-making and consistent monitoring of disease progression. So all of the respondents, patients, physicians, everyone agreed that treatment decisions should be made together and informed by the latest evidence. They also mainly agreed that patient education is so important. I mean, I'm looking in this room and just yesterday, seeing the engagement of the patients, you know your disease probably better than anyone. But when you were first diagnosed, what did you do? Did you have the right materials? Did you have the right support? So that was incredibly important, according to the Delphi survey. Also talking about the hereditary nature of this disease. So basically, when you find out that you have this disease, having patients informed so that their relatives are also tested so they know what's coming. I mean, everyone has heard stories of, a sibling or a parent that's been diagnosed with this disease, and you find out after the fact, but that may have saved someone else by getting them diagnosed sooner and managed it sooner. Lastly, they discussed a little bit about the importance of patient support groups. I know that this can vary across countries, across regions, but that they are important to have other patients that you can speak to. I mean, this forum is excellent. I mean, this isn't just a patient support group. This is a summit where different patients can get together and share their experiences, which I think is fantastic. Different countries obviously will have different access to these types of groups. So in summary, I think we learned most of this obviously makes sense, but other stuff may have came out that, especially in different countries, they didn't know what to focus on to provide this holistic viewpoint. So in summary, the Delphi panel agreed that Early diagnosis and treatment is paramount for initiation and coordinated multidisciplinary care. Maintenance of independence and quality of life is also critical for patients with this disease, and there should be family-oriented plans that are tailored to the individual patients, including supportive care. So we talked a little bit about rehab services, physiotherapy, all of that should be included. And lastly, an open dialogue to support shared decision-making and consistent monitoring of disease progression. So these were the three main buckets of which consensus was reached across over 27 countries with patient advocate groups and physicians. So in addition to this, there was also some guidance on how, which I thought was important, how allied healthcare teams can help patients improve and maintain their physical and social well-being. So we've touched a little bit on physiotherapy. This kept coming up time and again in the guideline recommendations. Home aids and modifications, nutrition, and access to nutritionists, and psychological support. So all of this should be included in a holistic care plan for patients in addition to whatever therapy they may be on. So in conclusion, really these recommendations are just a blueprint for how holistic care should be incorporated in patient management to help patients live independently and hopefully for longer. There are still challenges in implementation of many of these consensus recommendations. I mean, every town in Canada is different, every city, every province is almost like its own country, so having access to these different services is not a foregone conclusion, of course. But we really hope that with the help of TAC, that at least this study can at least generate further discussion to help identify needs that are not being met, and maybe in provinces where they are being met, we can apply those to other provinces where they are not, and countries where they are not. So I didn't want to spend too much time talking because really for us, we really want to know from you, what are the Canadian priorities and next steps? So is there anything that we've discussed or I just discussed today that is lacking? Is psychological support easy to get? Is it easy to get genetic counseling? Things of that nature. And if we don't do today, I know I'll be speaking with TAC about those. But we do know that TAC was a voting member on these consensus guidelines, so we did want to provide an update on them now that they're published. And we don't have to cover that. And with that, just wanted to say thank you and open the floor up for any discussions or comments that you might have. Thank you very much.
Hi there. My name's Stephen, and I'm suffering from HATTR with polyneuropathy. And from my experiences, I think these objectives are spot on. So they kind of give us where we want to go. I'm just wondering, do we have a sense in Canada right now who is doing this well? Because my experience has been that there's a lot of specialists. They tend to be a little bit siloed. They don't necessarily talk to each other. And when you're dealing with a rare disease, finding someone who does physiotherapy and knows about amyloidosis, or someone who does nutrition and knows about amyloidosis is extremely challenging, if not impossible.
So I don't have a blueprint or a document in front of me in terms of who's doing everything really well. What I've heard, and Marie, I hope, I'd love to get your viewpoint or some of the physicians in the room, but the sites where there is a true multidisciplinary network, I would assume or imagine that those provide more of this type of supportive care. But part of these recommendations are to work with TAC if it's not working and your physicians to find out ways to increase your access to those supportive networks. Is there any physicians that would like to, oh, no.
That's an excellent question and very important and a critical part of the care for our patients. And this is a challenging thing, as you know, right? And I think everyone in this room probably knows as well. Our hope is that the Amyloid Society, which will kind of officially launch later today, the Canadian Amyloidosis Society will play a large role in trying to understand this. This is one of the objectives of the care map of Canada that we're trying to build, is to understand what services are available where are the gaps, and if we don't know where those gaps are, how could we possibly start trying to fill them, right? And so it's a big undertaking. We know that there are, a few centers that do have multidisciplinary care, but even among those centers, the care there, which services are kind of readily available, which services have kind of more exposure or experience with amyloid patients, like physiotherapy, like dietitians, is also variable as well, right? So the first step is to kind of understand better where we're at, and then begin to try to address those care needs and those gaps across Canada as best we can. So we're trying. Hopefully, we'll get to where we need to go in the years to come.
Oh, Anne-Marie has a comment.
Thank you. Thanks very much, Chris, for that excellent presentation. Appreciate it. Unfortunately, I don't think those items are readily available for patients. And perhaps, and this is just a suggestion, maybe what we can do is, at the centres of excellence that we know of, perhaps we could design like a small brochure, like a one-page, with all the different things that a person might need, and ask each patient, when they're being diagnosed, what do they feel they need in terms of additional support, holistic support, in terms of moving forward. One of the other big issues that often comes up is the access to therapies, and it's such a long and winding road, for want of a better way. And perhaps there's a way that we can shortcut that for patients to get access. Because as we all know, early diagnosis is the key to, obviously, much better outcomes for patients. So I'd just like a few comments from you, Chris, in terms of, do you think that would perhaps be an idea, or is that not going to work? Because you guys are in that space that know best.
So also within these recommendations from the Delphi panel, there was this decision tree, which is pretty simple. It's, is this recommendation being optimized in my country or my hospital? And you could do this at the local level. So what you said is, oh, should we go to Dr. Fine's clinic and see, okay, is there a gap there that we don't know about, or Dr. Meze's clinic? And so basically, you're like, is this being implemented? Yes, great. Maybe we need to communicate that better. Is it not? Well, no. So how do we address that? Or like many of these, I don't even know what I don't know. And that's going to mean that we're going to require help from you, help from physicians, in order to bring that to life. But I think what Dr. Fine said is that first step is understanding what we can offer. That's likely the first step, for sure. In terms of, in your second question, was shortening the time to access. Yeah. So, I mean, there is a process that's followed. Colleen is going to be speaking about that actually in the next talk, which is quite timely, about the process. So you'll learn more about what does it take for a drug to get approved, and then what happens after that before it gets to patients. And there's quite a lot of work that needs to be done. And we, of course, and all of our industry partners will do everything we can to shorten that time. But I think that's a good segue that, Colleen, maybe you can address that in your talk as well. But yeah, that's a very good point as well. So, yeah. Hi.
Thank you so much. I loved the point about the agreement that genetic testing should be mandatory to confirm a diagnosis. And I'm wondering if you could comment on accessibility of genetic testing, either sponsored or publicly funded, for at-risk asymptomatic family members.
So there are a number of genetic testing programs, just to put it out there, so Alnylam sponsors one. Other hospitals will run their own genetic testing in their hospital, for example, in various parts in the country. And what's required for that, and perhaps one of the physicians can bring this in as well, is if you have a patient, you genetic test them, but then in order to test the family members, you need to get their consent and have those conversations before you can, and they need to be, I believe, enrolled as a patient before they can get their genetic testing. You can't just, yeah, exactly. Yeah. Mm-hmm.
But a lot of genetic counselors will
Yeah.
accept self-referrals. And that's usually the next step when a gene mutation is identified in the patient is referral to genetic counselors, both for that patient and for family members. Some clinics offer a letter to patients.
Yeah.
Some out to their family member just to say, what is this? You know, what do I have? You know, how may it affect you, and what can you do about it as well?
And we know that access to genetic counseling is, depending on where you are, is not,
It's also part and parcel of this map we're trying to build to understand, and some places have good access, some places have no access, and everything in between, unfortunately.
Hi. My name is Diana. I am caregiver. My husband passed away 3 years ago of age 58. My sons were diagnosed positive of, this is my sister-in-law, she is patient as well, and her son is also diagnosed. So we are family with a lot of, you can hear me? Okay, thank you. This is more a comment than it is a question. We did experience all those hardship of misdiagnosis and spending years of trying to figure out what it is. But I really just want to emphasize the role of the family doctor. I understand that we went through so many specialists, but the role that family doctor played, it's so important for the whole family, for the counseling, for connecting all those needs, and the role of the personal support workers, because you end up with needing them, especially if you have to go to work and support financially, economically, the rest of the family. So this what is happening, what I'm experiencing this second day, it's incredible. It's where we were 10 years ago, and now it's incomparable. I just want to thank you all for this is truly something.
well, thank you for sharing that, and very sorry about your loss. Thank you.
Yeah, I have to say, the problem there is that 20% of the Canadian population, or at least in BC, doesn't even have a family doctor, right? I mean, and so much of this is so frustrating, like to us too, because these all the physios and the psychological assistants, you know, they're not accessible, or we don't know where they are, you know, and then they're not covered. You know, it's a bigger problem than just communication between the amyloid clinics. Even if we have a amyloid at Vancouver, we have very good communication between the specialists, but it's the frustration of the actualists. Well, okay, well, we're just doing this, but you need more than that. You know, where do they go? I wonder if this is maybe where some of the patient, support, TAC could find out if patients have found out where there's a good dietitian, where there's a good psychologist in each of the local areas, put that up on the website somehow to aid in the other patients finding it. So not everybody has to reinvent the wheel. But yeah, in an ideal world, it would be one clinic that says, okay, here's your dietitian, here's your psychologist. But, you know, that is not there. You know, and we don't even have a nurse who's full with us. You know, so the hospitals don't support that. Then how do you hire these people? But it's true. Knowledge and communication maybe is the key to find out where they are each locally.
Thanks, Michelle. Yeah, and these are very much aspirational, for sure, because we know that access is not optimal right now.
Hi, thank you so much. That was a great talk. I have a comment and a question. The question that I have is that of the 50 points that the Delphi consensus outlined, 49 were endorsed. Could you let us know which one wasn't?
I knew someone was going to ask that.
Sorry,
I'm gonna have to dig hard
I couldn't
for that
hold
one.
myself back.
Yeah.
So that's a question. The comment is that I practice in Boston, so disclosure, I'm not Canadian. I'm actually not American either. So, but anyway, so you know, I think COVID brought terrible things upon us. It brought, though, a good thing upon us, which is, as an institution, we were allowed to have telemedicine visit unrestricted on the entire territory. That means that people that were seeking a second or third opinion could reach out to Dana-Farber or the Brigham and say, you know, I want a consultation, and then we will set them up and discuss with them. Most of what we do really requires looking at the data, talking with the patient, counseling. The visit and the physical contact is great if it can happen, but the contribution that we can give just by reviewing the records and figuring out what happened or what didn't happen is really crucial. And after the COVID pandemic was declared over, that ceased to exist. So the telemedicine visit we can no longer do outside of our own state because of lack of reimbursement. So I think if there was, and I don't know how Canada is structured in that sense, but I know for the United States, this is a big issue, you know, that patients just don't have access to tertiary referral center and large multidisciplinary clinic. And I think what you're doing here in trying to build a network, in trying to build accessibility to centers and foundation and people with knowledge is really critical to impact the lives of patients and their families who are affected from this. So I commend, you know, all of you for organizing these and working hard to this end. But can you answer the question?
So that is not in the publication that I saw. I will find it out. I did not look at the one that did not, but I knew I was going to get that question from some. I suspected I was going to get it from a different individual, and I thought I was in the clear, and I'm definitely not. But I will find it, hopefully, before I leave here today, and I'll let you know. It may have been very country or European specific, and it didn't apply to the rest of the world, so.
Hi, Chris. Sorry to be a bit of a pain this morning, but just a thought and just a suggestion. Why don't we, in terms of this project, have perhaps a pilot site? So it could be like Calgary or Toronto to try and implement what we feel is really, really important and see how that goes, and then copy that to all the other hospitals' main centres. Because then that way we could expedite it. There is a great awareness, obviously, in Calgary. I mean, I would say probably Calgary's one of the best examples, and perhaps replicate it in Toronto, Montreal, Vancouver, and that way we've all got a standard way of doing things. As I say, just a thought.
I think it's a great idea. I think we can have another discussion about that, especially once maybe in tandem with what Dr. Fine is working on now, of sort of compiling a lot of that information and getting these groups, these amyloid centers and physicians together in the first place, you know, for that care plan, and we would definitely look into supporting that for sure. So we'll talk soon. Yeah. Okay.
One thing that I've bumped into is, how can I say, with all due respect to the GPs in the world, educating them as a patient walking into a GP's office and trying to educate them about the nuances of amyloidosis and the kinds of things that are different. And I'll say ejection fraction appears to be a common thing that a GP would use to evaluate how healthy you are. And yet, while our ejection fractions appear healthy, we're not healthy. So how do we get that information without without sort of to the GPs, and how do we know that we know what we're talking about when we're talking to the GPs? To say, I've had a couple of GPs and they said, well, you're just healthy, you're fine, your ejection fraction's fine, and go away. And I'm going, but I'm not healthy. And I've read articles that say the ejection fraction is not the evaluation point for an amyloidosis patient. So that's a problem in the larger community, the medical community, and us patients bumping into it. I don't know if anybody has a comment about that.
I'd love to hear from others, but just so family physician education about the disease, and I'm sure there's hundreds of diseases that they can't be experts on, but of course, providing education, especially to physicians that might have a neuro or cardiac interest, we can certainly look into.
Yeah, it's another great question, another tough question, right? And you know, I think among physicians, family physicians have the hardest job of all of them, right? They kind of have to know about everything, and it's impossible to know about everything. And you know, I can just kind of focus on my little amyloid world and not worry about other problems, but not so for them. So, and they have a lot of pressures, of course, on them from all areas. You know, we don't have enough family doctors, as we've already heard. I think so. It's an important question. It's a difficult one to answer. I think we even chatted about this last year at the summit, if I remember correctly. And I do think and believe that reaching them early, maybe when they're in medical school, to make an impact. You know, and I think it was suggested even last year that when you see a patient tell their story in medical school, that's something that stays with you for the rest of your career. And so, you know, I think that's one strategy. There are efforts to engage with family physicians and primary care and offer education on the disease, which is important. And I think also just, you know, they may not necessarily know amyloidosis as the disease, but if there are resources that are easy for them to access, that they can learn more about it, then I think that's also part of the puzzle as well, is kind of easy access to resources, referral information, which is critical. And often that's a huge part of their challenge, is just trying to figure out what to do with a patient once they have a suspicion about something. And easy access to education. Those are all pieces of the puzzle to help kind of bring our primary care providers, you know, into the amyloid circle.
Yeah, just thinking further on that. During the pandemic, somebody was saying what was good. And actually, in Canada, luckily, in most provinces, we can still do telehealth. You can't do it for outside. Well, I don't know if you could do it for outside the province. You could, but it usually still is covered. But also, we were able to do some sponsored webinars or Zoom interactions with the family doctors through Axia, who's no longer making Intertersin. And it was for BC, Alberta family docs, initiated actually probably by a family doc who also had a wild-type TTR. So I think it was a very, you know, interested patient/physician as well. But I wonder, reaching out to some of their bigger conferences, you know, how we do these lunch and learns for the neurologists or the cardiologists online. That could be something that, frankly, pharma could be helping, because taking some lunch and learn symposiums of rare diseases, I think there'd be interest from the family physicians at some of their bigger conferences. Hadn't thought of that before, but I'm just thinking about that now.
Thanks, that's a great point. We'll take it back for sure. Okay.
Maybe just to add about access to, simple services for all our patients. I mean, in Montreal, we have patients, of course, who are from the city of Montreal, but I have also patients coming from, up north. They're driving 7 hours to come to our clinic. And so when they need access to any kind of service, they don't have anything in their small community. One thing that we saw from other countries, especially some European countries, they created some booklets, some pamphlets for each specialty. So, for example, what an anesthesiologist should know about amyloidosis, what a physiotherapist should know about amyloidosis, what a gastroenterologist should know about amyloidosis. And so basically, instead of trying to train a lot of patients about a rare disease, even if it's not that rare anymore, but it's almost impossible, but bringing the information to the healthcare provider, that's probably a more efficient way to do it. So I think maybe this is part of the thing that the Canadian Amyloidosis Society would develop in the future. But for example, for me, the other day I got a call from an internal medicine from a community hospital, and they had one of my patients, and they say, well, this patient is supposed to undergo a very simple surgery, but we're kind of scared because we saw it's a amyloidosis patient, so we think we should send this patient back to you, and the patient should have the surgery in your institution. I say, well, listen, you are 8 hours from Montreal, the patient is in the community. So let me give you all the information you need to know on how to manage this patient, pre-op, post-op, everything you should know. And then, they were very happy about that, and patient had his surgery in the community, and everything went well. So I think it's difficult for every healthcare provider to know about amyloidosis, as Noel said. Nobody can know everything about everything. So, but for all the center taking care of this patient, we need to teach, train, and provide documentation for every healthcare provider so patients can get access to all these services in their community. And actually, the patient can be by itself the one bringing the information. So, saying that, okay, I have this rare disease, this is my history, and you can get access information about my disease and how to manage myself on this website or contact this doctor, etc. So there's probably a great opportunity for this new society that we are going to develop in this point of view, and giving an opportunity for the patients to get access to a better care.
Thanks for sharing. That's a great idea.
It's more of a comment than a question. As a caregiver to my father with ATTR and a gene carrier and a physician, a medical doctor, and a teacher at UBC, and a member of the NMRA team, proudly, there's a lot of challenges and lack of consistent follow-up for the patients and their family members. Because I have so much, I'm so lucky to have so much resources, because I got connection with NMRA around more than a year ago. And without her assistance and the patient support of Pfizer, who are in person had connection with, my father would have not got access to tafamidis yet. So I myself, like even through Al-Nailam Act, I got tested, and I know that I am positive. And I'm just following up with the family physician who are, like, as Dr. Mezei said, like 20% or more of the BC residents doesn't have any like family physician to get any follow-up with them, or to ask them even for the Al-Nailam Act, like requisition, because like even genetic test needs to at least have a family physician to ask for that. And I have so many GP friends, family practitioners who are now in practice in BC. So I had to, in person, like educate them about amyloidosis, which sadly I haven't heard through my education in the medical school. And now I am just teaching like clinical skill and civil tutoring for like year 2 medical students in UBC. They haven't heard any, like even a word about amyloidosis. So I think like the finding the gap, figure out where we have to start to just make more awareness. It's basically a long way to go because like I'm so like lucky to have so many resources. So even with that much of the resources, I had so many challenges to face until to get the test done, until to find out if any of my cousins, if any of my like sibling is a gene carrier, and what to do next. I'm still, by the way, after 3 years of my dad being diagnosed, I'm still waiting to be called by the counseling, like genetic counseling from BC province. I haven't been called yet. That's it. Yeah, 3 years. Yeah. Okay.
Any other questions? Thank you, Kris.
Thanks, everyone.